Hello and welcome back to the Ophthalmic Referrals series. My name is Christian, I'm an optometrist, and the aim of this series is to offer some helpful hints and tips to my optometry colleagues in primary care who are making referrals to ophthalmology. In this episode we'll talk about YAG Capsulotomy referrals. I would encourage you to watch the first episode in this series because that covers all the generic information that should be included in any ophthalmology referral, and that will underpin this entire series. Please remember that this is how I would process a patient being referred for YAG capsulotomy, and you must use your professional judgment and follow any local and national guidelines, policies that may be in effect. There are many different types of ophthalmic lasers, and if you're a bit rusty, then there is a link at the bottom of the page which you might want to have a look through. In essence, the lasers can be subdivided into the type of media they use or the mechanism of action, but we're really focusing on the YAG laser in this case. This is the chemical symbol, and this is actually an image of the crystal which is used within the laser itself. I want to talk a bit about the cases that we wouldn't send on the YAG capsulotomy referral pathway. The commonest one that gets sent in error is for patients with occludable angles. Please remember that they should be sent to the glaucoma clinic, and the glaucoma specialist will assess them and decide whether or not they need a laser PI. The laser they use may well be the same one, but that really needs to be decided and approved by the glaucoma specialist. Similarly with SLT, glaucoma clinic first for those please. The diabetic medical retina colleagues also use lasers, but again we need to send to the diabetic medical retina clinic and let them decide whether a laser is required and which type. And similarly, if a patient needs to have cataract surgery, we don't want to be sending them to the YAG capsulotomy clinic. That would be a bit premature. Let's start off with the basics. Firstly, confirm that there is actually posterior capsular opacification present, which eye it's in. Make a note of the symptoms that the patient's experiencing, much like we would with a request for cataract surgery. Is it blurred? Is it distorted? Is there glare? And how is the PCO affecting activities of daily living and quality of life, with a few concrete examples to really justify having the procedure done. We would always include the refractive error and the monocular VA with any referral. Pinhole acuity, as you know, can be less helpful, and because it can be worse in these cases, but I think it's helpful to include that in case there are other potential causes of the reduced VA. And to confirm that the patient's aware of what the laser procedure is about and that they would go ahead and accept it if they were offered. There's a couple of links at the bottom here, a good one from Moorfields Eye Hospital, a patient information literature, so you might want to signpost them to that. And you may or may not be aware that this series, my YouTube series, separately, I have a series called the Patient Education series, and that actually includes a video on posterior capsular opacification, so by all means signpost your patients to that so they have a bit more information. What should we avoid in our YAG PCO referrals? You want to be careful here with your terminology. In my experience, there have been many referrals where it's unclear if it's a posterior subcapsular cataract, which needs to go to the cataract clinic, or if there's posterior capsular opacification, which requires YAG capsulotomy. Remember, when the lens has been removed, there is no subcapsule anymore, so as soon as the S or subcapsule creeps in there, then it can be quite ambiguous. So PCO, posterior capsular opacification. And again, cloudy and hazy media is ambiguous. It doesn't really differentiate between a cataract and PCO. There will be some exceptions to this, but generally speaking, it'd be unusual to do a YAG capsulotomy within 3 months of the surgery. Some would say even within the first 6 months. Once we've got the basics right, then we may look to upgrade our YAG PCO referrals. First of all, a bit more detail on the history. So approximately when was the cataract surgery done, and to give some idea of the visual potential of the eye, so previous refractive error and the visual acuity. It will help the surgeon to make them aware of any potential risk factors for complications, so previous retinal tear, vitreoretinal problems, inflammation, uveitis, CMO, because there's an increased risk of these things happening after the YAG capsulotomy. and glaucoma as well. You can get a rise in IOP following this procedure. In cases where the patient's really symptomatic but the VA is actually not that bad, you may wish to consider measuring the low contrast acuity. Again, that will just help to evidence the need and the benefit from undergoing the procedure. And it's helpful to exclude other causes of reduced VA. So if you can provide an OCT scan, particularly of the macula, a fundus photo is very helpful. And it's not that difficult to actually image the posterior capsular opacification itself. And again, that is just providing the evidence that it's there and that something needs to be done about it. Finally, a comment on the status of the other eye so that the surgeon has the complete picture for this particular patient. Thank you for watching this episode on YAG Capsulotomy referrals. Next time we'll focus on corneal referrals. Thank you.